Hello, and welcome to Rounds with Hopkins, a Johns Hopkins medicine podcast. I'm Dr. Bob Underwood. Today, we're discussing new research in fetal medicine focused on Twin Anemia-Polycythemia Sequence, or TAPS, a serious complication of monochorionic twin pregnancies. We'll be exploring findings from the study Fetal Hematologic Profile in Monochorionic Twins with Anemia-Polycythemia Sequence, undergoing serial transfusion and partial exchange. Joining us are two of the authors and experts from Johns Hopkins. First, an internationally recognized maternal-fetal medicine specialist. His work focuses on fetal therapy and complex fetal conditions, including TAPS and twin-to-twin transfusion syndrome, Dr. Ahmet Baschat. He's professor of gynecology and obstetrics at the Johns Hopkins University School of Medicine and director of the Johns Hopkins Center for Fetal Therapy. We're also joined by Dr. Alexandra Forrest, a maternal-fetal medicine physician joining the Johns Hopkins faculty this summer as assistant professor. Her clinical and research interests include fetal therapy and high-risk pregnancies, and her recent work on TAPS was recognized with the 2026 Society for Maternal-Fetal Medicine Scholarship for research in TAPS and monochorionic twins. Dr. Baschat, Dr. Forrest, welcome, and thank you both for joining us today.
Hello.
Hi, thanks for having us.
Absolutely. And so there's a really, really important study that you have both been part of. And Dr. Forrest, you presented this recently at a conference in Las Vegas. So what were the clinical gaps or management challenges originally motivating this particular study?
Well, TAPS is a relatively recently described clinical phenomenon. It's only been described for the past 20 years or so. And we have some neonatal data from which we can understand the hematologic profile, but really the fetal understanding of this condition was very limited prior to the study. We didn't have direct fetal hematologic profiles to better understand clinical management. And so the Center for Fetal Therapy at Johns Hopkins was uniquely poised to address this because of their high volume of TAPS cases, specifically that are managed with transfusion. And so we were able to leverage that data in order to better understand some of the hematologic complexities unique to TAPS.
And so what was the single most important or unexpected finding from your analysis?
There were a lot of findings, but I think what stood out the most was the dysregulation in the hematologic profile specific to recipients in TAPS. So in TAPS, there's a recipient and a donor. The donor is thought to send blood across small anastomoses to the recipient over time. And we saw a very striking difference in their hematologic profiles, where donors had anemia as expected and upregulated their hematologic activity appropriately in response to that anemia, whereas recipients had polycythemia and actually a dysregulation in their hematologic response to the polycythemia. So despite having very high red cell mass, both at the time of diagnosis and across serial procedures, we saw that polycythemic twins did not actually suppress their red cell response, which was unexpected in the context of what we know about normal fetal physiology.
I'd just like to add maybe a couple of important perspectives. One is that TAPS is predominantly being studied by neonatologists at the time of delivery, when it's easy to take a blood sample. And what you know is that you have one baby that has anemia and the other one that has thick blood. From that, people have sort of assumed that the path to getting to that point looks in a certain way in fetal life. The fetal blood sampling that's done is not, frequently used in a treatment because sampling twins, so getting actually a fetal blood sample, is a bit more challenging. And the centers that might do fetal transfusions don't get the whole range of red cell analysis that we were able to do here at Hopkins, right? So we actually looked not only at anemia and, polycythemia, but also how are the precursor levels, that lead to that. And that allowed us to actually get a much deeper insight that didn't really exist at all before the study was concluded.
Yeah, absolutely. And so how did these findings change or refine your understanding of TAP's physiology?
I think the dysregulation that we see in recipients points to a more complex pathophysiology than previously understood. So, as Dr. Baschat mentioned, most of our understanding came from neonates, and it was hypothesized that the primary mechanism of pathophysiology in fetal life was red cell transfer between twins. But what we can better understand now is that because of the dysregulation that we see in the recipient precursors, there's probably more than just red cells that are being transfused between twins. Potential explanations could be erythropoietin, a precursor for hematopoiesis, or the hematic precursor cells themselves may be transfused between twins. And there actually is some biologic plausibility that comes from another twin transfusion syndrome. So TTTS, which you mentioned earlier, has been shown to have hormonal transfer between twins. So we think that the biological plausibility already exists in another twin transfusion syndrome.
So based on that, what did the hematologic profiles reveal about fetal adaptation over time during serial intervention?
So we saw for specifically the anemic twins that over time, as the anemia was corrected with serial procedures, there was appropriate increase in fetal hemoglobin and appropriate downregulation in their precursor activity. So we saw that the anemic donors overall adapt as expected for normal fetal physiology, whereas the recipients did not have that same adaptation. So the first thing that was striking about recipients is that despite removal of red blood cells at the time of each partial exchange, at the time of the next procedure, we saw them become more polycythemic. They had more red cell mass, reflecting ongoing transfusion between procedures. And despite that, they still had evidence of hematopoietic upregulation in their precursors. So their sort of an adaptation over time was also dysregulated as compared to the donors.
When you're treating twins with TAPS, right, you have two options. You can either just transfuse the anemic baby because that one is the sicker baby in inverted commas, or you can transfuse and then also do a dilution of the blood in the recipient twin. Most providers in the community that treat TAPS with transfusions will only transfuse the donor because it's a single procedure rather than doing a second access to the other baby. And what this study also showed is like not only are the treatments temporizing, but the recipient is actually at risk of getting progressively higher and higher and higher blood counts if you don't dilute them at all. And so at minimum, you have to sample that baby to know how much of the cells that you're giving to the donor are making this baby's condition worse. That hasn't really been like studied at all before or demonstrated. So I think that's important so that when you temporize, you need to actually treat both babies. You can't separate them from each other.
Fascinating. So does the data suggest that some fetuses compensate better than others? And if so, why might that be clinically important?
The reason that the cells go over is because there's small vessel connections on the placenta, right? And they are random in size and number. The shunting potential that each pregnancy has can be quite variable between pregnancies. That means patients need to be managed individualized because you cannot predict based on the first sample how quickly you need to retransfuse the baby, right? And that's so you need to have effective monitoring, and you get to know the twins maybe after the second procedure or so to see what is their shunting pattern. There are individual differences between twins. Most serial transfusions in other fetal conditions are fairly predictable in timing, right? These are not necessarily that predictable when you need to repeat the procedure.
So how should these findings influence fetal surveillance strategies, particularly interpretation of the MCA or middle cerebral artery Doppler, or timing of intervention? If it's unpredictable, does this change your surveillance strategy?
The MCA Doppler is what we use typically for diagnosis in a non-invasive manner for TAPS. And because we notice, as Dr. Baschat mentioned, the unpredictability between twins in the rate of transfusion and the recurrence of anemia, part of the study was also to look at the MCA Dopplers and to understand whether or not they could actually act as a safety net to trigger reintervention while we're still learning the exact pattern of recurrence for a specific pregnancy. So typically, higher MCA Doppler is associated with anemia, lower is with polycythemia, though also a low MCA Doppler and its relationship with polycythemia wasn't particularly well known prior to this study. And what we found was that both at the time of diagnosis and then at subsequent procedures, the MCA Dopplers were highly correlated with fetal anemia and polycythemia, with a sensitivity and specificity above 80% for both twins. And so that was reassuring to us because it shows that the MCA Dopplers can really act as a safety net for clinicians in order to help time reintervention, given that we know there's so much variability between pregnancies. It's another layer that we have to inform reintervention.
This is interesting as well. So there was some information about how much blood goes between twins per day, right? That's based, I think, on 2 neonatal cases that were reported in the literature. What we calculated out is, it can be between 4 to about 10 milliliters a day transfer between twins. So, but there's over 10%, there can be a tenfold amount of variation between one pregnancy and another, how much blood goes across between transfusions. So that's why the MCA is really important. It's also helpful because a lot of patients come from far away. I mean, some of our patients came from other states, right? And so you are in contact with the MFM providers, and they would sometimes trigger an earlier appointment because they do MCA Dopplers as well. And that's great because it allows co-management with the MFM providers effectively and keeps patients basically safe throughout the treatment course, right? Because you try to get as far along as you can in pregnancy, really.
So in the study, were there findings that might challenge current assumptions or standard management approaches that are currently used in TAPS?
I think the most important one is actually there has been doubt about whether the MCA actually has a value, right? Because there are some society recommendations that say it's not established how good the MCA is and whether it's required in monochorionic twins. So there are some practice patterns where the MCA Doppler isn't done at all, or it is only done when there's secondary ultrasound findings that might suggest that TAPS is present or not. And I think what these data show is that the MCA is actually very relevant. It's relevant both in terms of its correlation with anemia as well as polycythemia. And the latter wasn't known. So I think this actually adds as good as evidence as you can get from observational studies that the MCA is very important in monochorionic twins. The other thing that I would say, some providers might just choose to do Dopplers if there are fluid abnormalities like twin-twin transfusion syndrome, and then they do the Dopplers. Well, in fact, the majority of these pregnancies had no other triggering signs. So the MCA is really a standalone important surveillance tool to detect TAPS and then monitor it. So that challenges the people that doubt the MCA.
So what are the practical implications for clinicians managing monochorionic twin pregnancies today? I think one of the practical implications is that the MCA is reliable in a lot of ways from what you said. Are there any other implications for clinicians who are managing monochorionic twin pregnancies?
the important thing is you can treat these with serial interventions. They're temporizing measures, but for patients that might not be ready to be delivered, you can get 5 to 6 weeks time until the babies need to be delivered. That's good to know. The other thing that's good to know is that you need to treat both babies, not just one.
So, what unanswered questions remain regarding optimal intervention timing, technique, or long-term outcomes?
I think there are several questions that we're eager to investigate after this study. The first is about the optimal management strategy. So we've mentioned several times that at minimum, the recipient needs to be sampled because of progressive polycythemia. But it'd be helpful to have more information about whether sampling alone is sufficient or a partial exchange should also be performed. So really understanding the optimal transfusion-based strategy would be helpful. And hopefully that's something that can be achieved with multi-center collaboration. We're also curious to better understand some of the pathophysiologic implications that I alluded to earlier. So the question of whether there's transfusion between twins of erythropoietin or hematopoietic precursors could hopefully be answered with additional studies actually looking for those precursors within blood samples. And then lastly, we know TAPS has neurodevelopmental outcomes that can be seen down the road for these twins. And so trying to better correlate some of the hematologic findings like the profound anemia at diagnosis or progressive polycythemia and how that might correlate with long-term outcomes could better inform clinical management and also give information to families who come to us in this situation.
Sure. And you may have already answered this particular question, but based on your answers to the last one, but looking ahead, what studies or advances are most needed to improve care for patients with TAPS?
This was presented not only at SMFM, but also in a multinational webinar that is also supported by patient support groups for TAPS, because TAPS, believe it or not, is actually quite an unrecognized disease in many areas, right? And so, number one, raise awareness. There are several staging, mechanisms for TAPS out there, which is unfortunately making it a bit more complicated to make the diagnosis. So the other thing is an MCA discordance of 0.7 MOMs actually identifies most babies that need an intervention. So that's number two. And then I think through multi-center collaboration, finding, okay, you need to treat both babies, but what's the best strategy and what modifications in the transfusion pattern gives you the safest treatment profile? I think those are things that still need to be figured out, but it's a very motivated international community, and we're very fortunate to have very interested colleagues. The other thing that I will also say is that many of the European sites that we've been in contact with, they haven't necessarily, done the detailed hematologic studies that we have had, although their laboratories may actually have access to that. Getting that information on a larger sample size is going to give us more knowledge, right? And that'll direct better research.
Or I think in our level of ability to exchange information in large sample sizes or larger sample sizes will only enhance that capability. So as we conclude, Dr. Baschat or Dr. Forrest, is there anything that you guys would like to add before we close?
Well, I mean, I would honestly say that this is for patients and providers. If there's any questions that anybody ever has, feel free to reach out. We'd be happy to provide any information on this, which is still considered a rare disease.
Well, thank you both for joining us and for sharing your expertise on this very complex subject. We greatly, greatly appreciate it. And to our audience, to learn more, visit hopkinsmedicine.org. And if you enjoyed this episode of Rounds with Hopkins, please share it on your social channels and explore the Johns Hopkins Medicine podcast library for more conversations on topics that matter to patients and clinicians alike.